14-year-old female, focal aware seizure followed by impaired awareness seizures, simple partial to complex partial seizures. Since 10 years of age, sense of unpleasant smell followed by loss of awareness of surroundings, staring, lip smacking, and repeated swallowing and chewing. The whole seizure lasts about 1 minute. Neural examination, normal. This is her preoperative MRI showing a lesion very suggestive of a cavernoma located at the uncus on the left side. And here is the coronal cut showing the same lesion, the cavernoma, over the left uncus with a halo of hemosiderin. These are the sagittal cuts. You see the cavernoma occupying the location of the amygdala, and the amygdala stay inside the boundaries of the uncus. So we have decided to use left terminal transylvian approach to remove the cavernoma. So this is the exposure after the dural opening. We have here the left frontal lobe. Here is the left temporal lobe. Let's go to the video. So the surgery starts with the opening of the sylvian fissure. You can use the 11 blade knife, you can use micro scissors, but the bottom line is you have to open the sylvian fissure so we can even see the uncus and we can see the cavernoma. So whenever it is very stuck on the surface, like in this case, usually in young patients, sylvian fissure is kind of stuck, difficult to open. One good thing is go deep, or you can follow an artery, because artery will always lead you to the cistern, to the sylvian fissure. Then if on the surface is very stuck, you can go first deep to the insular compartment of the sylvian fissure, find a major arterial branch, and then come back up on the surface to make a sharp dissection. I like to use cotton oil to protect the brain, against the suction tube. And keep splitting. At this point, usually the sylvian fissure is very stuck between the pars orbitalis and the plano polare. So it's patience and a delicate movement, and little by little splitting the sylvian fissure. Go to the deep, go to the insular compartment, find a major branch of MCA, and then proceed superficially, and then go deep, and then comes back up to the surface, and back and forth until the fissure is completely opened. Sharp dissection. But sometimes it's very difficult to split the sylvian fissure without a spatula. But sometimes whenever necessary, we can use just to hold the brain in place to make the dissection easier. If you cannot find a place, the plane to dissect, you can follow a major branch, arterial branch. It's very helpful. And so this is the most difficult part of the sylvian fissure splitting, which is the place where the pars orbitalis will be connected, not connected, but will be attached to the plenum polari. Now, after splitting this part of sylvian fissure, I like to put the gel foam to maintain this space open. So, but I don't see Uncus yet. I'm following M1. So continue to dissect. This is the posterior orbital gyrus stuck to the plenum polari. Now we can see the Uncus over here. Even the cortex is yellowish. So I've decided to approach from behind here. So coagulate and cut some small branches so I can mobilize and dislocate, translocate these larger arteries, so I don't have to sacrifice them. And then now I'm preparing for the corticotomy to get into the cortex. So I prefer to go from back to the anterior part rather than from here and then posteriorly. We can see we have opened the cavity with a little bit of hematoma, and then I will do a anatomical dissection removal of the Uncus. So what is the lateral limit of the Uncus removal? That's the rhinosulcus. So now I'm working on the Uncus. This is a subepio technique, very useful. You peel the brain off the arachnoid membrane, keeping the arachnoid membrane intact to protect it underneath important structures. So now we can see still working around the cavernoma. We know that for epilepsy cases with cavernoma, you have to remove the cavernoma and remove the halo of hemosiderin around the cavernoma to make patient seizure free. So I continue to work around the cavernoma until I find the normal white matter or normal gray matter. But you have to remove the halo of hemosiderin. Now, I've removed the cavernoma. You can see this is a pecum over here. And this is the third nerve. So this is after the removal of the cavernoma. This is the postoperative corona MRI of the patients, showing a total complete removal of the cavernoma. And this is the axial cut of the MRI, showing also the complete removal of the cavernoma. Postoperative sagittal cuts, showing the complete removal of the cavernoma. She remained neurologically intact after the surgery, but presented a tonic-clonic seizure on third postoperative day. But after that, she has been free of seizures.